Good morning and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg and I'm a research study coordinator with the Havey Institute. I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Very good. Thank you, Katie.
Our returning viewers will remember Dr. Murphy as the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID questions, infectious disease questions, and public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest COVID headlines through today, June 15th. We invite you to submit your questions below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. We're going to start today with some updated COVID statistics. We're still on the same number from mid-May that we have not gotten updates for of average case numbers. So that number is 10,305. The average new hospitalizations per day is 1,030. The average COVID death rate per day is 70, and the new booster proportion is sitting tight at 17%. Dr. Murphy, do you have any reactions to those numbers?
No, as you know, they're not really getting reported as vigorously as before, but I mean, definitely things are not going up in these bad markers. The number of cases per day has always been problematic since the advent of the over-the-counter testing, because those don't count, and that's where most people are making the diagnosis now. So you're only counted if you're in a CLIA approved laboratory, so an official laboratory that's reporting the cases, and some of them have, it's just not getting reported very much. So, but the hospitalizations that's a solid number, as are the deaths, and those continue to go down. So we're significantly below 100, 70 cases, people dying per day. That's the lowest it's been in quite a while. And that's great. So going in the right direction. We'll see how low it goes. We're definitely seeing clinically a lot of cases, but they're not ending up in the hospital. They're mild, and that's because of all the immunity that's in the community, plus all the people that have had the vaccines, including those with the new booster.
Absolutely. And has there been any updates in, the subvariant shift that we're seeing?
Yeah, it's kind of floating around here. And this is something that the CDC is looking at actually pretty closely, because if this changes, a lot of things can change, including the hospitalization rate and death rate, if we all of a sudden get something that's more lethal or can escape the protection that we have from our prior immunity and from the vaccines. So the CDC's latest variant proportion estimates indicate that XBB 1.5 has decreased from over 50% to approximately 40%. And the other XBB variants, these are all Omicron variants, by the way, the 1.16 and the 2.3 continue to gain ground. So you're seeing this shift in the different variants that are floating around there. These are all sort of behaving about the same and responding to the natural immunity and vaccine immunity that we all have. So it's at this point, it's good news.
Right. And that point about shifting variants is a very good segue into our first submitted question from the week, which came from one of our viewers asking if the R0, R sub-zero, as you may see, number for a disease changes, especially in the case of COVID with the different variants. Could you tell us what R0 is and a little bit about it when referring to COVID?
Yeah, we talked mostly about this at the beginning of the pandemic. R0 it's a number that people just don't think about every day. But in terms of infections, if the R0 is less than 1, that means for every infected person, fewer than 1 will become infected, and that means that the infection will extinguish itself because it'll just get less and less and less. if the R naught is greater than 1, in other words, one person who's infected affects like 2 other people, well, that's an exponential rise. 2, because then 2 gets 4, 4, 8, and so forth. If it's between 1 and 2, it goes up more gradually. So that's what R naught means. And many studies have been published about this. And the first strains that came out in 2020, the R naught was approximately 2.7 to 3.2. And there were estimates around this worldwide. And in 2021, the R naught, this was when Delta came out, it jumped up to 5. The R naught was 5. So it basically, it doubled, much more contagious and a more serious disease. Then Omicron came out, but it tells you why Delta took over. Remember, that took over in the summer. It was August 21. So then the Omicron came out in the beginning of 2022. That R naught was 9.5. And in South Africa, it was 24. I mean, that's like really contagious. This is up in measles territory, all right? The XBB variants, which are the Omicron variants that are floating around now, have come down to about 1.6. So it's still growing, but it's much less than what it was. So why is this? There's 2 things. One is that it's the virus changing, all right, becoming more contagious. But the other thing is the population is more resistant to getting infected or to getting seriously infected, or at least getting diagnosed. So it's those 2 things that are driving this whole R naught thing. And it's down, but it's still growing. I mean, there are cases all over the place. There's little upticks in New York. We've got cases here in Chicago. I just had a dinner last week. I don't know if I mentioned it last week, but 1 out of 6 people in our little group couldn't come because they had COVID. So COVID is still floating around out there.
Right. Still definitely something to keep an eye on and be aware of. And then our second question from a viewer asked, is there any proof that vaccines can cause long COVID or make one more susceptible to it?
Mm-hmm. This has been looked at very closely. Remember, there have been, I think it's over 13 billion doses of the vaccine have been given out worldwide. There's a lot of data. I mean, even in the United States with about 70% coverage, I mean, it's in the 200s plus million people have taken it, all different ages from 6 months and older. There's been a lot of vaccination out there, and the vaccines do not cause long COVID. COVID causes long COVID. And that's definitely happening. Now, almost everybody, even if you got vaccinated, has also had COVID. That's called a hybrid person, because you have the immunity from the disease and the immunity from the vaccine. And there's no difference in the rate if you had the vaccine or not had the vaccine. So the vaccines don't cause long COVID. Long COVID is caused by COVID.
Absolutely. And moving on to some of our headlines related to those XBB variants, there was recent news that the FDA has continued to put out advising for the new round of boosters. Can you tell us about those updates and what makes the new boosters different from previous ones?
Yeah. So we had the original vaccine, and then in September of 2022, they modified that and included the Omicron protein, that the major circulating variant at the time. And that has shown to work much better than the original vaccine. So if you got a vaccine after September 1st, 2022, you had the new bivalent vaccine. A lot of people don't realize that they had the new one. It was after that. So now the question is, should we change this vaccine or not? The FDA is it's still the official recommendation, but the companies are now developing specific Omicron, these XBB variant vaccines would be the next new vaccine or modified vaccine. The FDA, I think, is meeting this week to the advisory committee to discuss this. I had a question from a reporter from Reuters yesterday about this. It's a great idea because the immunity to the original Wuhan virus that came from Wuhan is, that immunity doesn't help you against Omicron. So just like with the flu, we don't give the same flu vaccine every year. We modify it based on what's floating around in the Southern Hemisphere before our flu season. So yeah, it's going to change, and I would imagine that they are going to recommend that we just switch over to a whole Omicron-based vaccine at this particular point. That's my guess, but I'm not the advisory committee or the FDA. I speak for myself, but we'll see what they say. They may be meeting today. I don't know. It's sometime. I thought it was this week that they were meeting.
Sometime very soon. And that's a great point about the flu shot changing every year. It's something that we always
have to. Every year. Every year it changes. So, the same thing is going to be with this, because most likely the next variant, if there is a next variant, will be more related to Omicron than the original virus. So, you will likely have, some protection from the newer vaccine rather than the older vaccine.
Right.
Yeah.
Well, that's very interesting. And moving on to our next headline, there was a very interesting story regarding outpatient treatment with metformin and the efficacy of that drug. Can you tell us a little bit about the study and some of the findings?
Yeah, metformin has been around a long time. It's available generically. They use it in diabetes and other diseases, and it's inexpensive. So what happened? So last Thursday, a study was published showing that treatment with metformin reduced long COVID by 41%, with an absolute reduction of 4.1% compared to placebo. So 41% decrease in long COVID, that's huge. This was a really good study with over 1,000 patients, over 1,200 patients. Placebo control. So, everybody got a pill, but you didn't know it was metformin or not. So, that's the rigorous design. Now, it was high-risk people only. So 30 to 85 years, overweight or obese, had COVID symptoms fewer than 7 days, and had a documented severe acute respiratory syndrome with positive antigen tests. So it's a high-risk group. And there were a couple other little groups they had in there, and they found that the metformin was beneficial in all the different groups, and it was consistent. Now remember, these are all outpatients, so not really for sick patients in the hospital, but it's if you're in one of these high risk groups, you can take metformin as well. I would do it next time.
Absolutely. It's always great to be getting more research and more news about drugs that we do have that are inexpensive and somewhat easily accessible from your doctor to help out that we kind of need.
Yeah. The other thing, these other groups, some of the other groups had ivermectin and fluvoxamine, these other drugs that have been used to treat it, and they didn't, the metformin is what worked.
Absolutely. That's great to hear. So another study that came out very recently had some startling findings revolving around people not regaining their taste and smell following their COVID-19 infection. Can you tell us a little bit about what the researchers found?
Well, yeah, no, this is, it's a retrospective study. So looking back in time, doctors from Boston looked at 29,700 patients from a study they had been doing. And I mean, the good news is smell and taste go together, kind of. So 72% had full recovery of smell, and 76% had full recovery from taste. Another 20% or so had partial recovery, but there were, 3.7% for smell and 2.6% had absolutely no recovery. So, I mean, it shows you the risk. I mean, the risk is still low for no recovery, but even there's an awful lot of just partial recovery. So it may take quite a while to improve, and some people may not improve. There's still something under study. So remember, the recovery is over time. So these people need to be followed for even longer to determine if some of that is really permanent. If it is permanent, it looks like it's less than 5%. So that's good news.
Right. I mean, that's just a scary story. Taste and
Yeah.
smell seem so just
Well, just
integral to
another
life.
reason not to get COVID and not to get lung,
Exactly.
and to take your metformin as well.
You take your metformin and get your new booster when it comes out.
Right. Get the new booster that works better. Mhm.
So, kind of speaking about the perception and how we think about COVID, there's been a lot coming out recently about how the pandemic has really shifted the public's perception of common colds and other respiratory viruses. Uh, how are doctors really looking at that, and what data are they really seeing?
Yeah. So when COVID came in, it basically took over the respiratory market, if you want to look at it that way. And I don't know if you remember, but in 2020 and the flu season from 20 to 21, there was almost no flu. I mean, COVID outbeat the flu. Now that it's kind of subsided, all these other respiratory conditions are coming back, and people get colds all the time and flu-like symptoms all the time, whether or not it's flu or not. And because there was that period where people weren't exposed, they became more susceptible to these things. So there's been a series of, there's been a recurrence of these things. And remember, almost all these infections are viral infections that do not respond to antibiotics. Antibiotics do nothing for viral infections. So people are getting tested just for COVID. And if it's not COVID, they're taking antibiotics. So this is wrong, because most of these infections are viral. Now, what's happening is the NIH, our National Institutes for Health, has really been pushing very hard to for the companies to develop multiplex assays. In other words, it can test against flu A, flu B, and respiratory syncytial virus or other viruses. You're going to see more and more of that, so people can actually get an accurate diagnosis. But just throwing antibiotics at everybody who's COVID negative is not the way to go.
Absolutely. And in your opinion, do you think that because we had spent such a long time, in isolation with masks on, that could have some effect on our, immune systems kind of quote unquote picking back up or catching up to all the new things we're exposed to?
We're now getting exposed now without the masks and all the mitigation, social distancing and small groups and whatever. We are exposed to less. So in a way, it's good. You're not sick as often, but in a way, without that exposure, you become kind of more at risk later to get kind of the same thing, because these things are all very contagious.
Right. Well, thank you, Dr. Murphy, so much for your time and expertise answering these questions and reacting to both COVID statistics and headlines. We welcome you, as always, to submit questions down below with our email or anywhere that you can find us. We have links down below into the description. Thank you again, Dr. Murphy.
Okay, thank you. Have a great rest of the weekend.
Thank you. Have a great weekend, everyone.